know people are still going to be coming in, but I wanted to first welcome everyone so far to our virtual learning collaborative, clinical integration across care settings. We're super excited to have you guys all here to learn more, and I couldn't be more excited to introduce you guys to the Optum team of Carol, Sherry, and Natalie, who will be attending other sessions. They're great. They're going to be teaching you so much, and I'm really excited to see how much you guys can take away from this. So I'm AJ. I'm here from the SNAC team. I know a lot of the team captains have gotten emails from me, and that'll continue to happen. Please email me, anyone, all participants, please feel free to email me at any time throughout this whole virtual learning collaborative so that I can answer any questions that you might have. Just a few logistic concerns before we start. Please make sure on the top of your Adobe Connect screen that the speaker tab, which could be green for a lot of you, is unclicked and it isn't green. That actually gives a lot of feedback, and it might actually hinder hearing some of the important parts of the session. So if you guys can make sure that's unclicked, that'd be great. The other thing is, with cell phones, whatever you're calling in with, your headset, we would prefer if you guys will be on mute unless you're speaking, just because that also will, gain some feedback and that'll take away from what we're trying to do. So other than that, I want to let you guys enjoy what we're doing, and I'll pass it on to Sherry and Carol.
Great. Thanks, AJ. I just want to welcome everybody from the Optum team. It's an exciting opportunity to talk about clinical integration. I think as we explore the topic, we'll see it's kind of one of those new buzzwords, and what does it really mean, and we're going to do a deep dive into that. We want to make it relevant for each of the organizations. We did a questionnaire, and we sent it out through AJ to folks, so we really appreciate the information we got from team participants, and we tried to build that in to our presentations. But I'm a little concerned, I'm a worrywart, that when we have a lot of folks on the phone, I know we're trying something different this time. So participants, we have a team captain from each organization, and some folks have a lot of people behind them. Other folks are sort of the Lone Ranger from their organization. I don't think there'll be chaos, but I think sometimes the discussion gets invigorating and exciting, and everybody's got a different point of view, and that's the beauty of a virtual learning collaborative. But we want to try and control it so everybody gets to talk. So, we don't want people to hog it, and we don't want, people to miss their chance. So just a couple ground rules. Every group needs their norms, but we don't want to waste time. We recognize that everybody's got day jobs, and really applaud you for applying to this virtual learning collaborative, making time out of your busy day. None of us have a lot of free time, a lot of responsibilities, so you giving up an hour and a half for, the session for the next 6 sessions is a big deal. So in respect to everyone else, if you could make sure you sign in on time, and, maybe just sign in like 5 minutes before and hit the bathroom and get something to drink, and then we'll be ready to go. I think AJ suggesting, putting your phones on mute. It's not that we don't want you to talk, but again, we want to try and control we want you to walk away with content, but we want to build on the content with your experience, your questions, your insight. So this is new for us. We're going to try and remember to say, okay, open up for feedback. If we don't, there's a chat box. Chat everyone, just write your chat down there, and between myself, Sherry, and AJ, we're going to try and pick up on those, but we'll also try and remember to say, okay, unmute. We're asking that the team captain sort of coordinate the correspondence or the communication, or say, okay, it's so-and-so team captain, XYZ member in our team wants to have a comment. Again, we're going to see how that plays out over the collaborative, depending upon level of participation. We just don't want it a free-for-all. Questions are welcome, so if something comes up while we're talking, like when we did last session, we mentioned some things, didn't expand on it in the presentation. Somebody shot us some questions. They wanted more, I don't know, information about something. It was fabulous. We gave the information. We welcome that. If we don't have the information, we had a session last time that we knew the answer. We just couldn't remember the product name. It was a new product that's coming out from NAC on social determinants. Anyways, we got it and got the information out. So please, we learn from your questions. We learn from what you share. Again, we respect that you have day jobs, but we're looking for commitment. We think if we give you a little homework assignment, it will encourage you to become engaged with the process. So at the end of every session, we've got a homework session. We're not giving you an A, we're not giving you an F. You do what you do. But we really would encourage you not to work in a silo. The whole beauty of a virtual learning collaborative is not only sharing with people from all over the country on this call, but make sure you go back and you take it to your org. You may have a lot of people from your organization on the call right now, or you may not. You may be the lone wolf. Please go back, and if we have assignments, rope the people in that are your stakeholders. Rope the people in terms of clinical integration. Who are your stakeholders? Participants from our sessions have found that's really the most valuable for them. It's nice to sit in these calls, but at the end of 6 sessions, you want to be able to do something with the information. So our homework is a cumulative kind of thing. Each session builds upon itself, and it then will prepare you for the last session, our 6th session, where each of you, the team captains, or however you decide, will be making the presentation for the 6th session. So I'd encourage you to keep up. We know life gets in the way, and people have got kids, parents, job responsibilities, so you don't get a slap on the wrist, but try and keep up. At the end of every session, there is a survey monkey, and AJ has that under I think somewhere on the screen here reminds you about the survey monkey. Please try and fill that out before you as soon as you hang up, or fill that out. Natalie, Sherry, and I are just always like saying, AJ, what was the feedback? How can we make it better? And I'm sure you folks are like that in your organization too, that quest for raising the bar, making it better. We want to meet your needs. So please, we want it. We love positive. We love to hear how great we are, but we take the comments, the suggestions for improvement to heart, and we really try and incorporate those. If you have questions between the sessions, I am available. My name is Carol Dahl, and my email address is there. It's pretty easy, caroldahl@optum.com. I can try and answer your question. Usually I'm the one, I don't know much about nothing, and I find someone that can answer your question. But, if we don't know it, we'll get you an answer or rely upon the power of the group. So with that, let me introduce myself quickly. Then I'm going to have Sherry introduce herself from the Optum team. And then we're going to turn it over. I'm going to have AJ maybe do a roll call, or however AJ wants to do it. And we're going to have you all introduce yourself, because this is the exciting time. We get to figure out who's who and where there may be some potential alliances. So I'm talking too much already, but my name is Carol Dahl. I'm a master's prepared nurse, certified case manager. I've been with Optum about a year, and I've been in the Medicaid ACO space. Natalie Ellerton is not with us today, but she's our vice president. She's amazing. I'll let her introduce herself on the next call, but I wanted to put a plug in for Natalie. And then I'm going to let my wonderful colleague Sherry introduce herself.
Hi, everyone. I guess it's depending upon where you are. It could be morning or afternoon. A good day to you all, I guess is a better way to state it. I've been with Optum for 5.5 years. I've held a variety of roles. I, too, have a nursing background, but haven't done clinical nursing for a very long time. I've been mostly in the business space. And my work with Optum has really been on the business development side. I've been working the last 1.5 years with Natalie in Medicaid and helping Medicaid providers across the country who are taking on risk. and helping them understand kind of what that means and the capabilities that go along with it.
Great.
I guess.
All right, well, let's turn it over to participants. AJ, do you want the honors of facilitating the participants' introduction?
Yeah, so I have a list of all of the organizations. So I think what a good way to do this would be if the team captain of each organization, when I say the organization name, if you guys want to introduce yourselves first, and then other participants of the organization, introduce yourselves right after the team captain. So why don't we start with the Collaborative Ventures Network. Well,
if someone is on mute, we cannot hear you.
Yeah.
Is there a team captain name, AJ?
Yeah, is Ginny Roberts on? I would. Some of the participants might be running late, or I don't know. Some participants might be able to go. So I'll go down the list, and please just speak up and unmute and go ahead. So let's start with let's go with Hudson River.
Hi, this is Megan Hardesty from Hudson River Healthcare, and I'm joined in the room by my colleague. You want to introduce yourself? Sure, Allison Laquadera.
What's your role, ladies, with Hudson?
So we have formed an IPA jointly with a set of behavioral health providers called CBH Care IPA, and I'm directing the IPA, and Allison is a project associate for that.
Awesome. Can't wait to learn more about you guys. Behavioral health integration is huge. Welcome.
Welcome. Thank you.
Great. Okay, next, do we have anyone from the Healing Community Center?
They're out healing.
That's great, but hopefully next time they'll be here. Let's keep going. How about Hope Health? Okay, well, we'll have to move on then. I want to keep this going, but if anyone from these organizations are on the call, please feel free to unmute at any time and speak up. So the next one, let's do PH and S in Washington, Providence Health.
Hi, this is Leanne. I don't know if you've got Providence Health in Washington. We're actually in Alaska, and the group we have is the Alaska Care Management Consortium. So my name's Leanne. I'm a master's prepared nurse. I'm the Regional Director of Senior Services for Providence here in Alaska. And I'm also the project director of our HRSA grant. We just were awarded a 3-year Small Healthcare Provider Quality Improvement Grant. And through the grant, we have created a consortium of critical access hospitals and federally qualified health centers to start practicing some collaborative work and care management and navigating the HIE.
I'm so excited to have Alaska participating.
Yeah, we are so happy to participate. There should be hopefully a few people on the call to introduce themselves too.
Hi, this is Anchorage Neighborhood Health Center. Sandra Woods. I'm also a master's prepared nurse. I'm the nurse manager, and so I also supervise the care coordinators, which are going to be for our participation, a critical piece of this puzzle.
Hi, and I'm Sarah Bayless. I'm the Chief Operating Officer at Anchorage Neighborhood Health Center.
Hey, this is Stephanie Ameline. I'm an RN case manager at Providence Family Medicine Center Outpatient Ambulatory Center with a residency. And we've got a team of 7 over here today, 4 RN case managers and 3 behavioral health representatives, including a group coordinator.
And I'm
this is Kathy Kloster. Go ahead.
Oh, go ahead, Kathy.
Oh, sorry. This is Kathy Kloster. I'm the RN case manager in Seward, Alaska, which serves a population of about 5,000 people. I'm the sole case manager for this hospital, and we live in a community with very few services, no home health. We don't have care coordination in the community, basically. So there's very few services.
Beautiful Seward.
Yeah, beautiful Seward.
Is Seward home of Hobo Jim, the Jimmy Buffett of Alaska?
I don't know that.
Don't know Hobo Jim? Okay.
No,
And this is Pauline Doucette. I'm from Providence Valdez Medical Center, another critical access hospital within the Providence family. We're very similar to Seward, and we are the snow capital here in Alaska.
I'm picturing Valdez. I spent a month in Alaska. Beautiful Valdez. Anybody else from Alaska?
Yes, hi, my name is Amy Sorter. I'm here at Providence Kodiak Island Medical Center. I am the nurse case manager here at our critical access hospital.
And I'm Deb Seidel. I am the Director of In-Home Services, which includes home health and hospice and ministries that we care for people in the home and in the community.
Is that your team, Leanne?
Yeah, we've got another team member who was unable to call in today.
Leanne, you rock on. You did a great job getting everybody together. Thanks, Alaska. Thanks, Providence.
Great. Okay.
Who we got next, AJ?
I think we have two more on this list. How about VNA Healthcare?
Yes, that would be me. That's Laura Barrett from VNA Healthcare. We are, I'm located in Aurora, Illinois. We have 10 clinic sites that cover Kane County, DuPage County, and Kendall County. We're a federally qualified health center. My area of coverage is the Associate Vice President of Population Health Services. So I cover case management, care coordination, home health, hospice, and our house calls program with our providers that go out into the home. So a lot of the areas that have already been identified are areas that report into me and that we organize here, along with exchange of clinical information back and forth with around 14 different hospitals around our sites, along with urgent care sites and physician practices. I'm here by myself, though. I'm real impressed with all the people up in Alaska. Is there anybody else left up there?
Yeah, we've got plenty more.
Well, Laura, it sounds like you got a lot going on there, so I'm sure you got people to support you. I'm from Illinois, and you've got beautiful Kane County and DuPage. Welcome. We're glad you're here.
Thank you.
Awesome. And the last one I have on here is Minnesota Association for Community Health Centers. Is anyone on the call from that organization? Okay. Is there anyone that I missed? Any organization that I did not mention? Okay, great. I think we can move ahead, Carol.
Great. I think it's important that we went through the introductions. Hopefully your ears kind of peaked up. You know, if you want to go visit Seward and now you have a colleague there you can go visit. But the most important thing is, we're going to learn more. Who's doing what roadblocks, what successes that we have. And from other collaboratives we've done, people reach out to one another. It's not just the people here doing the presentation. It's, we're all in this together and we're all learning. It's a whole new world out there. But let's talk about, what we're trying to do in this learning collaborative. What we're hoping that you walk away. I think our last session is in December. That's hard to think that, this beautiful summer weather, and we've got December for our last session. But what we're hoping you're going to walk away with it at the end of this series is, we want you to understand there's different kind of contracting models out there, different value-based contracting models. And a contract is more than a contract. Given what you've got, what you're signing up for, and you're reviewing it, does it make sense for your organization? What are the implications when you implement that contract, when you strategize for that contract? How are you going to try and integrate that across the various care settings? How are you going to do that? What do you need to think about? What are the successes? What are the barriers? We want you to be able to build and we'll be talking about health neighborhoods. We want you to be able to know what the foundation are. What is the fundamentals of going about building one? If you don't have a strong foundation, your house is not going to be in order. So how are you going to identify what you need? Because I'm sure Laura at VNA is going to have some of the same issues that Leanne has in Alaska and her team, but there's obviously very unique differences with the population, the contract, the payer, your resources. So what are the fundamentals involved? We want you to recognize or appreciate what we call the criticality of governance. At Optum, our bias is, the top sets the tone, and you really need a strong governance process in place to guide you, to support you, to help you set the vision and the strategy, not only for where you're going to go. It's great to have the idea and the vision, but sometimes when you get these things going, despite all your planning, hopefully it goes well and everybody's in sync and it's kumbaya, but sometimes you're going to have some little bumpy roads. So sometimes the bumpy roads are fun and you tweak it and you move on. Other times you might have performance issues. You might run into maybe you didn't price it right. So the importance of governance to make sure that ongoing you've got a management structure in place to make sure that you deliver your services seamlessly across all your different care settings. And as we venture into these new types of opportunities and arrangements, to look at potentially what are new requirements that are out there that are going to support you in integrating your systems and to collaborate. Collaboration sounds good, but sometimes you've got challenges in doing that. So that's kind of the big picture, where that's the trip we're going to go on. That's the adventure, the vacation we're going to take in the next 3 months or so. So that's the big picture. Where we're at today, session 1, the topic for today is the business case for clinical integration with value-based reimbursement. Why are you doing what you're doing? How are you going to build the business case for integrating clinically? So what we hope you're going to get out after today, Sherry and I are hoping that you're going to understand the different type of contracting models out there, the different types of various value-based contracting models. Sherry's a real whiz kid on that, and she and I are going to be going back and forth in this presentation, and she's going to review that with you. We want you to understand what is the business case for clinical integration in value-based contracts? Why you're doing what you're doing? And finally, we want you to appreciate how across the care setting, depending what type of contract model you choose, clinical integration can vary. There's different components, different considerations in mind. So we want you to be aware of those nuances, those variables, those factors, and to appreciate how they're impacted by the different contract model. Sherry, did I capture it? Any comment there?
You got it. I think we're good.
Okay. All right. I'll open it up. Any questions from the audience before we move on? Okay, let's get going. All right, so I referenced, sorry, I usually don't talk so much, we go back and forth, but you all know AJ and I sent a questionnaire out to folks because we wanted to see, what's Alaska doing? What's Illinois doing? What's everybody up to? So we sent the questionnaire out. Thanks very much for your feedback. I got to kick somebody on the call. It was just precious. They were like late in returning it because they had worked so hard with their organization to get buyer input, and that's amazing. So let us know that feedback when you do it. It's a beautiful thing. So one of the questions we asked you was, are you currently involved in any value-based contract that involves risk? Tell us what it is. And we tried to go, Sherry and I tried to go through and try and summarize the responses. And if you work from top to bottom, summarizing, we didn't do it exactly the way people responded, but we've got some people in this collaborative, nope, they've got no value-based contract with any risk in it at all. There's nothing on the horizon, or maybe there's something on the horizon, but as of today, nothing's in place with value-based contracts. Next level, kind of moving up in terms of risk, is some folks have contracts where they're incentivized based on quality and utilization metrics. So those are things like, if you reach a certain threshold on getting the A1Cs for your diabetics, or if you cut down length of stay or readmits, those sorts of things. So some folks on this call are dealing with that. Some folks are moving towards a total cost of care arrangement apparently in the next year. Other folks are working with Medicaid and some of the new government initiatives where Medicaid is transitioning their payment for services, and they've contracted out with managed care organizations. So the states, you all know this, contract with the different MCOs in their state, and they with providers, and they either have fee-for-service arrangements or capitation. And then again, depending upon the organization, some had a mixed model. Some was capitated, some was fee-for-service, some also had pay-for-performance measures in there. We had FQHCs who are participating in ACOs, accountable care organizations. And I think someone was moving towards a clinically integrated network, a CIN, in an IPA model. So given the feedback we got, this was sort of an overview of where you all are at. I think I'm going to open up the phone lines to see if we missed something, or boy, this healthcare scene today, it's changing like by the minute, it seems like, and new relationships and new contracts are emerging quickly. Is there any model that is new or we may have missed? If you'd like to unmute your phone and throw it out there, if there's a different model that you're currently involved with that's not captured here.
Hi, this is Leanne from Alaska.
What you got going on, Leanne, that's different?
Well, our Medicaid office from DHSS just put out a request for information. So they're looking at a care coordination demonstration project that may include any type of risk-based contracting. So moving toward would probably be where we are right now.
Okay. So the door is open, RFI is out, and you're moving towards it. Good, good. Anybody else?
This is Laura from Illinois at VNA Healthcare. We also are starting to see that move towards that with our managed Medicaid plans, MCOs, looking at probably a 2 to 3 year window for that to get into a value-based capitated reimbursement structure.
Yep. Value-based is coming. It is coming. Okay. Thank you very much, team. So just so we're on the same page, we thought we'd start with some sort of a definition or some guardrails. People, there's no right definition. I suppose there's some definitions out there, but just so we kind of all have the same understanding. What are we talking about when we're talking about VBR, value-based reimbursement, or VBC, value-based contracting? It's how you get paid. It's a payment methodology between the payer and the provider. So who's paying, who's providing the service, and it's designed to promote the triple aim. And again, everybody knows this, but we want to, decrease costs, improve outcomes, increase member satisfaction. So it's a shift from reimbursing for volume, ka-ching, ka-ching, fee for service. Every time you see a provider, they submit the claim and you get paid for each encounter you have, each procedure you do, to one that's for value. So it's not counting, each time you touch them, it's what's the outcome? What are you getting for that? It's designed to save money. Nobody's got enough money in this country, and everybody's looking to save money. It's too expensive. And the research is showing there's such variance in the healthcare and such variance in how we provide care, to diabetics. Are you seeing them twice a year? Are you seeing 3 times? And the costs are all over the place because of this. It doesn't mean cookbook medicine, but what's the best system and the methodology to provide care? So it's designed to save money while improving outcomes. And what do we mean by outcomes? I mean, these are kind of like the gold standard. If you can start knocking these out, you're ahead of the game. So can you decrease your inpatient admits, or maybe even before that, decrease length of stay? Decreased inpatient admits, can it be done in an alternate care setting? I've got length of stay, decreasing length of stay, ER diversion, keeping people out of the ER, reducing hospital-acquired infections, things like that. And, finally, wellness is here. Everybody talks about wellness, but if you get that mammogram, if you get that flu shot, it keeps people well and it saves costs. So you're trying to get a healthier population to save dollars. So, it sounds great to talk value-based reimbursement and contract. It's hard to do. It's complicated. It's risky. We're going to go into, how you work with the contracts, but it is here to stay. And depending what you read in the environment, some people are saying, oh, it's a long time in coming. Others are, no, it's coming. But the feds and CMS are really leaders in this, and with Medicare and I know we're a Medicaid safety net group here, but with Medicare and the advancing numbers of aging baby boomers in Medicare, they are pronto moving to value-based reimbursement, and the feds are saying, it's going to be coming, and they're going to be serious, and 50% of it in government programs, the Medicare and Medicaid, is going to be 50% by 2018. I'm going to let Sherry talk a little bit more about, moving from the volume to value, but before we switch, any questions or any comments at this time? Okay, take it away, Sherry.
Great, thanks. So this slide, I don't know how many, some of you may have seen this. Sometimes it's referred to as the S-curve. And it's really moving from the fee-for-service to fee-for-value, and it's really showing kind of where many of you are at in this orange transitions box, or as Natalie would say, you have one foot on the dock and another in the boat, and the boat is starting to move away from the dock, and it's just a matter of how fast are you going to move. And it's a tough place to be, exciting, but still kind of a tough place to be, because the challenge is you're moving from that operating model to a business model. Taking on more risk on the bottom side really requires a new set of capabilities. And so, it's really trying to understand where you are, how fast are you going to move, and what capability sets do you need. And we'll get into clinical integration around that, because it certainly is a part of that business model. And depending upon the value-based contract that you're going to pursue or looking at doing, some of those capabilities in that clinical integration is going to look a little different. So here is a slide that really talks a little bit more about, the farther you go to the right, the higher the level, the more mature your organization really needs to be to succeed. And, as one way of looking at, there's a bunch of different models out there. These tend to be the more common ones, the ones that we've seen across the country. The pay for performance typically is where some folks have been. Moving into bundled payments, and sometimes depending upon your discipline, that one could be hard, particularly if you're not doing knee replacements, if it's very hard to identify those episodes. Then we get into shared savings, or shared savings and shared risk. And we typically see, bundle payments are going from pay for performance to shared savings only. And then maybe a step beyond that is shared savings and shared risk. And then finally, global capitation, where you actually become a health plan. And there is a movement of more and more providers actually becoming health plans across the country as well. And that takes a whole nother set of capabilities. So, you start learning the behavior, maybe in the pay-for-performance world. You start transitioning really as you move up into shared savings and developing additional capabilities, and then you really need to transform your care delivery if you're going to move into global cap. It's really going to be expansive. That's one way to look at this. Let's see, I hit all the types. Comments, questions? Have you seen this before? Is it making sense?
Sure. So I'm just going to interrupt. Somehow I've gotten disconnected, so I'm going to dial, try back in. So if I miss MIA, you know what's happening.
Okay. Thanks, Carol. Comments? All right. We will move on to the next slide. This is actually a real-life example. We thought it's helpful to actually see what's happening out in the marketplace. And this is taken from the state of New York. And there the state is shifting risk to the provider community through a program they call DSRIP. And that stands for the Delivery System Reform Incentive Payment Program. A mouthful, yes. Like DSRIP better. But they're allowing the Medicaid payers to go out and contract with what they call performing provider systems, or PPSs. And they can select the level that they're going to be contracting. And a lot, of course, depends upon the PPS and where they are in their journey and what amount of risk they want to take. But we thought it would be good for you to see this level 0 is really explaining more around the pay-for-performance world. Level 1 is really shared savings. Level 2 is shared savings and shared risk, and level 3 then is the capitation model. And so you can look if you are actually more around an integrated primary care setting. This is the kind of the gist of what the contract would look like. So just something that, again, it's different. Every state is going to be different across the Medicaid environment, but it gives you an idea of actually the things that are out there. And certainly what the state of New York is hoping is that over time, there's going to be a movement across these levels, that more and more will be taking on more risk, and that will be shifting. One of the things to keep in mind, I guess, with this, as you've seen and as we've talked about, is that, value-based contracts will have cost and quality targets in their algorithm. That's not going to be different. It's just a matter of, how much risk based on that is going to happen. How many of you have seen a similar model to this? Been exposed to that out in any of presentations or articles that you've read? It tends to be kind of a common predictor of a picture of what the shared savings model looks like. And this gets a little bit down into kind of what this is going to be. In today's environment, in the fee-for-service environment, if you become more efficient, you actually lose funds because you actually are reducing the number of widgets or the number of services. A shared savings model is really an incentive to actually still become more efficient, but still be able to share in the savings that you may generate. So how it works, you're going to start with a per member per month cost. Usually health plans will help you figure out what your starting point is. And if you follow the dotted line, that's what the traditional projection would be for your system. That's what they would typically see. But if you go in and you're going to be become clinically integrated, so to speak, or you're going to develop those capability sets that are going to help you succeed to manage the population that's going to be attributed to you, then the hope would be is that say towards the end of 2017, you're going to be where that dark gray bar is, which is, this is your new target. This is actually what happened. And that generates the gap between the dotted line and the dark gray bar. And then the gray triangle there then indicates that's the savings that would be sent back to you. That's what you would get in return for your efforts. Questions, comments, making sense?
You know, I'm thinking, Sherry, as we're presenting this, and I hear folks' backgrounds, it seems like we have a lot of clinicians on the phone, which is marvelous. So some of these business models and the financial may be new to them. So I just want to say you guys probably already know it, but if you don't, no question is a dumb one. We want you to learn and understand so you can, you know, take information back to your org. So any question, any comment is good.
Hi, Sherry. It's Leanne from Alaska.
Yeah.
On your last slide, level 0 was your normal fee-for-service plus bonus. Yeah. And so has that already passed? So in New York, what level are they on now?
No, it's going to be different, right? So this is just the model that the MCOs can go out and use as they contract with those PPSs. So an MCO might contract with 4 different PPSs, and each PPS may be at a different level.
Okay, and so where does the bonus? So is that saying, like, you know, here we want to start practicing, we want to start trying, but we don't want to take the risk yet?
Correct. Yep.
Okay.
Exactly. So a lot depends upon where they are in the build of their capabilities and infrastructure, and sometimes it's just even how the formation of the PPS. So is the provider system, is the PPS a brand new entity because of this model, or is it, you know, maybe it's a set of all FQHCs under the same tax ID who might already have be farther along in their clinical integration, therefore they're able to take on more risk. They might jump right to level 1 or maybe even a level 2 if they feel confident in their ability to get consistent outcomes.
Okay, great. Thank you.
Yep.
Yes.
Okay. Other
Good
questions?
question.
Yep. All right, so we're going to dig just a little bit more into a value-based contract. And, you know, I think Carol set it up, but it's really important for you to understand some of the nitty-gritty in the contract itself, because that's actually going to drive your clinical integration efforts. If you don't understand these high-level components within the contract itself, you won't have a very good idea of where you're going. So consider this as kind of your goals based on, you know, the making of the contract, and that again will help drive even your project plan around building out for clinical integration and help you be successful. So these are some key terms that you should see in a value-based contract, and we'll have AJ open up the sample contract here in a minute. But I want to talk a little bit about what these are. How many of you have heard of attribution and know a definition for it? How would you define it?
This is Leanne.
Don't forget to take your phone off mute, guys.
This is Leanne. So it would be a patient population that would be attributed, so that would become participants in your program.
Okay.
Patient attribution.
Yep. And do you know how your patients are attributed?
Voluntary or mandatory?
Say that again, I'm sorry.
I said whether that would be voluntary or mandatory.
Okay. Yep. There are some MCOs or some programs that say you're automatically attached to this provider. And some of those, there's prospective and retrospective attribution. And I think the prospective is one similar to it's kind of a mandatory where you need to select a provider or a provider is selected for you in some situations. So you know on the front end who your population is that you're trying to manage. That's the best case scenario because then you can kind of know what's happening with them up front. And then there are retrospective attribution methods, which tend to happen through a preponderance of, say, number of visits with a specific type of physician, whether it be primary care or sometimes it could be a specialist provider like an endocrinologist who might see people for diabetes, that kind of a thing. That's important because that helps you understand, geez, am I going to know on the front end who my patients are that I need to follow and manage, or are they going to be attributed to me behind the scenes, and then how am I going to handle, my business model or even my clinical model might change a little bit based on that. And so it's a matter of understanding how the contract is set up and how you're going to know who your patients are. Then, of course, there's the total cost of care, actual and projected, as we talked about in that in the shared savings model in particular. But certainly, as you think about even other risk-based models, it's important for you to understand what is the baseline and where am I trying to go. And these things that are listed under that are just as important to understand as the component of total cost of care. How many, I'm sure most of you probably have understood risk adjustment. Do you understand the importance of risk adjustment and why that is needed? Anyone?
You don't have to say your name. You can throw out the answer. We don't hold opinion.
We're just giving an idea.
My understanding is the risk adjustment is the patient population that you have and the risk assessments that are completed. So you have usually high, medium, or low risk with it. And that can be internally, or it could be done even with the MCO plans, could be identifying, which most of them are also identifying, and usually having different scales with it. So then working off of that risk adjustment will then identify the patient population that you're working with and meeting your financial resources to support them. And that may not be completely correct. I'm not sure.
No, it's very, very close. That's right. I mean, there's a lot of risk adjustment methodologies out there. I don't know that one's any better than the other, but what the risk adjustment really does, and some of the government programs use it to determine your payment. And especially if you think about total cost of care, the risk adjustment actually helps you understand your population and the resources that are going to be needed to manage it. So the sicker a person or the more comorbidities that person has, the greater the risk that they have. Therefore, in a total cost of care model, they're going to allow for the addition of resources to be able to manage that patient. So if you see someone and you are not coding all of their diagnoses, they're not going to get captured at the right risk level, which is going to affect the amount of dollars that you could potentially receive for that patient. Or it's going to affect your total cost of care might look less than it actually is because you aren't capturing potentially all of the problems that a particular patient has. So that's number one. And then it's also to help you at some point to stratify your population so that you, as you do population health management efforts, you're selecting those folks, what I call the low-hanging fruit, those people that hopefully you can manage utilization better so that and actually get them to a point where they're managing their chronic conditions as well. So they're reducing cost. And that's typically where a lot of people start in the world of value-based care. They start, by those highest risk members, and that's some of the risk adjustment. And then there's trend as well, and then, of course, IBNR and claims run out, and making sure that as you're looking at your contracts, you understand those components because, again, as you think about over time, and I'll go back to this slide, over time, your trend is going to be this dotted line. And if that dotted line isn't really reflecting what we think the trend is going to be, it's going to impact what your target is, which is going to impact eventually the shared savings that you're going to get. And then, of course, understanding, what's the claims leg in the reporting and the data that you're going to be getting, so you understand when you start seeing data that supports where you're going or where you're at, that you have that in mind. Of course, data sharing, data privacy. Data sharing really comes around to, if you're going to be taking on risk, you really need to get the data. You need to get information on those attributed members. It's going to be care that's happening outside your four walls. So you actually can see a bigger picture. Just some of our ACO clients across the country, when they get data, claims data on their attributed members for the first time, it's appalling to them the amount of care their members receive outside of their four walls. In some situations, it's 55 to 60%. That's not unusual. So if you're responsible for meeting quality metrics, and Mr. Jones has received his flu shot at the Walgreens, and it's helpful for you to know that, so you can get credit for it, number one, but then also so you're not being redundant in services. You got the quality measurement, understanding what are the quality measures that you're responsible for and what's the algorithm behind it, and then also stop loss. So stop loss could be a different, it really comes into play when you move up that spectrum of risk. And today, self-insured employers is a good example. They might buy aggregate stop loss, so they limit the amount of risk that they have, and that's one way to do it. We're not going to spend a lot of time on it, but as you move up that risk spectrum, just something that you might want to consider. So AJ, if you could open up the sample contract. By the way, all of these documents are in the downloadable files. So I'm not going to spend a lot of time on this particular document, but I just wanted to put something in front of you that you can take with you as you move and you start getting into the contract arena around value-based reimbursement. And really this highlights those items that you should be looking at more closely. And for those of you that are looking to do clinically integration and integrated initiatives, again, this can be kind of the baseline or the foundation of that work that you're going to do, because these provide the means to the end of where you need to go and kind of what your outcomes need to be and can be your goals. And then it's just a matter of how are you going to get there. So think about, we talked about, again, the quality, and oh, by the way, this is a bogus example. Some of the language in the definition or the terms is good, and some of it is not so good. It was kind of, we used it for a different exercise. But the fact of the matter is, if you think about the issue piece and the importance of understanding what that is and the downstream impact it might have on your organization, it's just helpful for you to have kind of as a guideline as you work through this. And then as you get better, if you end up with, you develop your first value-based contract with an organization, you have some learnings, you can get to the point where you can actually drive a lot of this discussion with the MCOs or your payers that you're contracting with, so you have some similarity between them. So if you're working with 3 or 4 MCOs, for example, you can get to the point where you can actually, based on your clinical model, drive some of these details so you're not in a situation where every contract is quite different. That's not helpful to you or your patients either, because that's hard to track and it's hard to manage. Okay. What questions do folks have? A lot of information, I realize.
What's with the, so quality measurement, we talked about that. What was with the stop loss, Sherry?
That was the ability to manage risk, to put a cap on the amount of risk you're willing to take.
Okay.
Hi, this is Leanne from Alaska.
Yes.
So when we convene as a consortium with this HRSA grant, one of the main goals is data sharing, and one of the main outcomes is that we all navigate our Alaska Health Information Exchange to do this data sharing. But if we're not involved in a contract, an ACO, that type of program, how do you get past the all of the compliance pieces for sharing data?
That is a very good question, and I am not sure I can answer that. Carol, do you have any thoughts?
I'm gonna flip it and say, do you have a legal consult available to your organization, either through your legal department at the hospital, one of the entities, or compliance staff?
Oh yeah, we do. We're working on that, but I didn't know if there was anybody on the call who's actually experimented with it and kind of figured out a way past it. Sometimes it's a real big barrier. I'm hoping the HIE is what's going to make it happen. I also know that patient, having the patient sign consents and that type of thing. But I didn't know if it's a big problem. We're just practicing, and so until we actually enter that ACO and we have that patient information at our fingertips, how do you really go about sharing data?
Yeah, I was involved with an ACO formation in Illinois, and I mean, my experience with it was just, HIP, BAAs, business associate agreements. That was all handled by the legal folks, and then it got a little complicated because you think it would be so simple. Everybody wants to get together and everybody share information, and especially for the behavioral health was at Hudson River folks. When you add sharing of behavioral health information, that puts a whole different other level of security because of that protected information. So I'd say just work with your compliance folks and legal experts.
I think the only other thing that I would, and this is a little bit not necessarily answering the specific question you have, but as you brought up your HIE, I think one of the things that you need to consider is make sure you're realistic about what the HIE is going to provide, because a lot depends upon how that information is coming across. But in most situations, the data is such that it's not necessarily going to get to be actionable at the provider level. So it might be a point of reference, but I think you just need to be cautious about what it actually is going to deliver for you, because we've seen that challenge as well across the country. People think that the HIE is the solution, but it really is not. It helps, and it's a step in the right direction, but I just caution on how far it can take you in that endeavor.
Thank you. That's really valuable. Thank you so much.
Yep. Any other thoughts, questions, concerns? Is a sample contract going to be something that you think will be able to help you think more about? And maybe if you have time between now and the next session, feel free to bring back questions if there's anything on there that needs more explaining.
And you're going to be using that contract in your homework. Renee's on welcome, no. Renee. I know you joined when she was with us last time. We used the contract for a different purpose, but you'll be looking at the contract as part of your homework. It's a lot to take in on a 90-minute webinar. So don't forget to download the attachment so you have it and take a look and use it.
All right. Okay, let's go on to the next slide. This one probably looks familiar to many of you. There's a lot of challenges related. And so if you think about the current environment, and value-based payments are going to inspire providers to solve problems differently. And they certainly do, because the incentives are quite a bit different. But today, here are some of the big challenges. You have a fragmented view of patients. You don't have a clue because you don't get the data on what's happening outside your four walls. If the systems aren't necessarily aligned, it's going to make care management challenging. Talk about integration. What does it mean? I mean, you've got a bunch of folks that are trying to compete for business, not necessarily collaborate. There's going to be a lack of alignment between payers even, right? And you've got what you're trying to do and what they're trying. They're trying to hold down costs and you're trying to increase revenue. So a lot of that can make the world very, very challenging, as I know you've experienced. And we also know there's going to be a wide variation in clinical processes. This really creates inefficiencies. And it's not just between one location and another. Wide variation exists even within the four walls. And we've seen that over and over and over again. If you are a clinic that might have 6 physicians, you might have a different rooming procedure for each physician. That's very common. That's what we see. And then we see, if you're small, you may not have enough population or resources to take on risk. There needs to be some scale within your organization, some amount of attributed membership to actually take on risk. And if you think about CMS, for their programs, sometimes they have a 5,000 minimum attributed membership. Sometimes it's a 10,000 minimum membership. And so that's something else to consider as well. How big are you? So that you can actually manage the peaks and the valleys related to that risk contract. And then again, competition prohibits collaboration and communication, as we know. I mean, if you are one system and there's another system 2 blocks away and you're both vying for, the membership, you're competing. Whereas in tomorrow's world, now you want to start working together. And so the incentives do become a little bit different. All right, Carol, I think it's back to you.
Okay. So want to open up for a little bit more dialogue here. We're almost more than halfway through. Just people need to get up and stretch. But talking about what is clinical integration, I think it's a buzzword right now. And just to make sure that everybody's kind of on the same page, I'm going to open it up. What are people's thoughts about clinical integration? We've got mostly clinicians on the phone. You signed up for this session on clinical integration. There's no right or wrong answer. Speak from your heart, from your gut. What is clinical integration to you, or what is it to your organization? What does it mean to you? Let's open it up.
This is Deb. I'll take a stab at it first. The biggest thing to me that I see clinical integration is it's the communication and the coordination of care across all the areas, and so that it's looking at that patient holistically and integrating the various aspects of care and wellness that are necessary for that particular patient's health.
Deb, appreciate you saying your name. If you don't want to say your name, I don't want anybody to be embarrassed, but I think you hit on a very important component, communication. We're going to be talking more about that. Coordination across all the areas. Sometimes we don't know all the areas where our patients are going. And the whole thing of member-centric care, being holistic, and it's more than just taking care of the diabetes or the asthma. Wellness. What is wellness for them? Is it getting the flu shot? Is it getting the mammogram? Our behavioral health colleagues on the phone today, the diagnosis of depression and treatment of depression, especially with the comorbidities of chronic illness. Excellent point, Deb. Excellent. Anybody else?
Yeah, this is Laura from VNA. I just kind of echo on to that there also. I look at it as more of a seamless interaction of all the disciplines that interact with that patient, both internal and external to your organization. So it could be community agencies, it could be specialists, it could be hospitals, it could be clinic settings, it could be convenient care settings, it could be behavioral health services that are interacting with the patient. And then within those areas, even all the disciplines that are in there. So nurse, social work, nursing assistant, counselors, pharmacists, dietitians, physical therapists that all interact with that patient. So they have both access to any communication back and forth, but also can participate in that communication back and forth, and always working with that patient to be in their own self-management of their medical condition.
So you think about, I mean, that's amazing, Laura, what you said. You think about how we're doing it now. You know, EMRs don't talk to one another. So we used to run provider offices, and our fax machine was burning up, right? Or the stuff would sit in the portal and the docs didn't know how to access the portal, or, you know, the pharmacy real fills and Walgreens would be calling 16 times. You know, it seems really easy, and it's not. You also mentioned, I forget the term you used, Laura, you brought up excellent point, urgent care, the whole advent of, oh my gosh, these retail clinics. You know, are they part of your scene? How do they fit in? So, and you mentioned all the people. You know, it's no longer, you know, the physician in the physician world. We have all kinds of new roles out there to help the member with their care. Really valid points, Laura. Thank you.
Hey, Carol, Pauline put one in the chat.
Oh, Pauline, you don't want to talk? Integration, coordination, minimizing waste. Pauline, you are spot on. You know, some of the research shows if we get rid of the waste and the rework, the money that we save, redundancies for holistic care of individuals within population groups. Thank you. Thank you. Excellent. All right, well, let's give you, you know, a formal definition. And AMA was one of the first ones to come out with a definition. Not surprisingly, and I'll just read it, boring, but I'll read it to you. The means to facilitate the coordination of patient care across conditions, so all the different diagnoses, the providers, various settings, and time. It's not just Monday through Friday, 9 to 5, and nobody's available on, you know, the Friday after Thanksgiving, in order to achieve care that is safe. You know, all the work that the Joint Commission has done with sentinel events and wrong site surgeries, that is safe, timely, effective, efficient, there's your waste, Pauline, equitable, everybody's treated the same, using evidence-based guidelines, and patient-focused. I think we mentioned most of those things. American Hospital Association says, again, just another definition, it's needed to facilitate the coordination of patient care across conditions, same thing, providers, settings, and time in order to, looks like the same thing. Here, we got a typo here. Sorry, guys. It's the same thing. Here it is. To achieve clinical integration, we need to promote changes in provider culture, redesign payment methods and incentives. And I don't know. That doesn't seem right. Let me get back to you on that. That doesn't look right. All right, so when we sent the questionnaire out to folks, we asked you, what did clinical integration mean to you? And what you told us, sort of a combination of everybody, was that it was delivering primary care with behavioral health care in the same setting, with clinicians working together in a team-based approach. Working together to promote value-based quality care via patient-centered medical home in our network, integrating physical, behavioral, oral health. In our last session, I just always like to plug this, we had a dentist who is just amazing, and I think changed all the participants in our last group about, finally behavioral health is getting its day. What about dental? But becoming the anchor for care management or care coordination across the service community, an integral part of the statewide provider network. Let me get back to you. I made a typo in that slide, and I'll get back to you next time or get out to you about the AHA definition. But I like what we came up with. So in order for clinical integration to work, and in order for us to implement it, sounds like a good thing, but there are some challenges to making it work. I think about what we talked about earlier. I was involved with an ACO, and we were so proud of ourselves. We thought we were really controlling utilization, and then the state is slow in paying bills, and then we got the bills, and it was like, oh my God, all the leakage going to other places. So having the data is important. But anyways, what are some of the problems with clinical integration? You've got a fragmented view of patients. As what you do really well in your FQHC or your behavioral health setting, and you knock it out of the park, and you think you do it well, but how do you know what's going on once they're outside of your domain? So with a effective clinical integration network, it's going to allow for seamless, and I think that's what Laura mentioned, it's seamless view across the continuum of care. Another challenge is when you've got different systems and they don't work together, care management can be challenging. Frankly, it can be a nightmare. Not knowing, oh my God, med recon and transition of care and knowing what meds people are on and lab work. And, Sherry mentioned we're going into the flu season time of year, that they got it at CVS, Target, Walgreens, whatever, and not getting that information. So if you've got a really effective CIN, you're aligning the information and for your patient, your population, and it allows you need to develop that government structure that we talked about. You have the leadership that helps you oversee and come up with a common clinical model. How are you going to treat hypertensives? Are your diabetics always going to get an endocrinology referral? Are they going to see the ophthalmologist for that dilated eye exam? Are you going to use an optometrist? What's your clinical model going to be? There's lack of alignment. If you're not integrated, there's a lack of alignment between payers. I'll never forget, I ran some physician practices, and we got into capitated arrangements, and it was great, but some of my providers were incentivized. They were based on RVUs, relative value units, so the more things they did, the better they got. They were furious. Somebody didn't think that out. So these poor guys and gals were reimbursed by that, and we kind of held on to them. It caused all kinds of problems. So everybody's got to be in alignment between how you're getting paid. So you got to know how you're going to get paid. Are you okay with that payment? What does it really cost you to provide that care? Now's the time to be measuring what is your cost of care. What is it costing you to do it? How are you able to track your costs? There are times you may have peaks. Sometimes wintertime. I've worked with Medicaid populations, a lot of high-risk people, inner city, a lot of homelessness. We couldn't find these people, so it cost us a lot of money once they went to ERs and got admitted for nothing, but at least then we found them and we could then engage them. But there are, seasonal variances in knowing your costs. So you got to have those analytic capabilities. I think sometimes you either have no data because your systems aren't talking to one another, or sometimes as you begin to integrate, there's so much data and you need to be focusing, don't get too aggressive. Focus on, the top things, the inpatients, the ERs, the readmits, but make sure you've got somebody who can crunch that data for it. And some clinicians are fabulous at interpreting the data. Others need a little help, but you can learn and get a good ally and somebody to help you interpret that data. Wide variation in clinical processes. It's a real problem when you begin a network. You all want to work together, and you've identified different FQHCs or partners to deal with, and you go into these risk-bearing contracts. But if somebody, gets a call on a Friday night, my kid's got this, and your standard response is, we'll send the kid to the ER, it's going to cost you a lot of money. So how are you taking care of those things? Or, how often are you doing A1Cs? What are you looking at evidence-based guidelines and creating your clinical protocol so you don't have that wide variance in clinical care? Let's see. Real problem for some states is there's not enough, again, depending on the state, there's sometimes network adequacy issues, and you have problems getting enough providers in certain geographic areas. There's not enough providers, or their panels are capped off, or there's providers, and you may not want some of those providers in your network because of quality issues. And in one of the upcoming seminars, we're going to talk about that, how to pick providers. So, consider partnerships on how to maximize efforts in working together. And Sherry alluded to this earlier, the competition prohibits collaboration. I was involved with an ACO with different FQHCs that came together. And before everybody, was doing their own thing, and I'm the best FQHC, and I've got more patients, and I've got more contracts. So it took a lot of work to bring the FQHCs together to say, how do we build a network where we each, maximize our own resources and share best practices and work together? Okay. Sherry, I'm going to turn it over to you.
Yep. So here is just a snapshot of potential. Along the left are some capability sets, and then across the top is a spectrum of potential contract types. And really the capabilities that are needed to be successful related to the contract type. And if we talk about clinical integration and kind of the attributes that need to follow it, it's going to be driven by the type of contract that you're going to move into. So let me give you an example. If we look at a bundled payment, a clinical integration activity related to that is going to be quite a bit different than if we look at a shared savings model. So bundled payment is a very defined episode, and it's a knee. So the clinical model is going to be a little bit easier to define as well. You're going to have the pre-op, you're going to have the surgery, and you're going to have a post-op period of time. And so the integration that's got to occur is going to be between the services that are done pre-operatively, lab work that might have to happen. You can define the clinical model, but it's probably getting the primary care physician in there, the surgeon in there, maybe some prehab, as they call it these days, and then the hospital and the appliance, what's going to go into the knee. And typically there's going to have to be a decision around the governance. The leadership is going to say, okay, this is the appliance that we're going to use. It's the lowest cost option with the highest quality. And then how many, what's the post rehab going to look like? So the clinical integration among that piece is going to be pretty easily defined. When you go into a shared savings model, you're talking about population health. And so it's going to be more longitudinal, so it's going to be a longer period, and you may need more structure and infrastructure related to clinical integration. So some of you are talking about, care coordination or case management. And with a high-risk patient, that could be a couple of years potentially, right? So how is everybody that's going to be involved and touch that patient for what you're going to be held responsible for, how are they going to communicate? What really needs to happen with the integration, the clinical integration around that? And sometimes it can't be just sharing data. It's about this fourth one down. It's the shared care plan or the shared care of that individual and the responsibilities and accountabilities. Who's doing what when, and how do you know they're doing it, and how do you know it's been done? So that, and then what's the next handoff? And how do you look at that, and how are you going to know? So a lot of times, the more you get into higher risk, the more infrastructure you're really going to need to make sure that that integration does occur. And then, even if you talk about tracking, communicating, and Carol talked about this in the previous slide, how do I know that we are succeeding, those of us that are working together? How do we know that we're succeeding? And I think many of you would feel the same way, that data is very powerful because it's fact-based, and that can really help. So I think, I didn't go through every single scenario here, but hopefully if you take it back to the contract, know what you're being held responsible for, understanding the components of the contract on how much risk you're taking, and that should drive your clinical integration activities for each one of these. And certainly, I think the more risk you take on, the more important the governance structure is going to be, because you're going to have to come up with a common clinical model. And particularly if your entity is made up of a number of disparate systems like the IPA. These are folks that used to be competitors that are now coming together. It's going to be important that you've got a strong governance structure so everybody feels like their voice is heard and you can maximize those resources and really develop that clinical integration that needs to occur. So before we open it up for final questions, our hope was that we could show you a video, but the technology is such that it's not going to work. So I'm just going to give you a little bit of a history of a case of a ACO. This was in the Twin City market, and it was based on some of the initiatives the state had done to contract in value with FQs. And this one happened to, it was 10 FQHCs that came together to form what they call the FUN network, or the Urban Health Network, Federally Qualified Urban Health Network. And they have been together now since January of 2013. And they became an IPA as well. And they had 3 committees that were formed. They had a board of directors, so each one of the FQs was represented on the board of directors. They had a clinical quality improvement committee and finance committee. And so this was their governance structure that they set up. And again, it had representatives from all the FQs to come together. And over the 3 years that they had contracted, they had some great results, and we'll get there. But they had 32,000 attributed Medicaid patients. Their focus was on primary care interventions because while they worked with hospitals, they weren't the hospitals were real reluctant to give them some data. So the data that they had was claims data that they received from the state, and they really focused on transforming their clinical practices to provide effective clinical interventions and then care coordination for those members. And it's just a very, very cool story because, they saw the power of what coming together and collaborating could mean. And they were one of the first in the country to take on this kind of initiative. And over the 3 years, this is what they were able to do. They reduced their ED visits by 20% for their attributed population. They had total cost of care reduction for the 3 consecutive years of that contract. The first year, they had a 3.1% reduction. The second year was 4.6%, and the third year was 4.9%. And then they earned 99.14% of their quality bonus in 2014. So they really figured out what clinical integration was and had some awesome success. And lots of learnings along the way. And I think one of the biggest ones that they would say that they had was really that collaboration that they came together and what they were able to share as a team in a new initiative. If at some point we can we get this video up on our website. We'd love to share that story with you. It's very powerful, and I think can be somewhat motivating for those of you that are moving into that arena. All right, 5 minutes left.
Yeah.
Carol, you want to cover homework?
Sure. All right. We're going to have you put together some of the lessons that hopefully you've learned today. So go back, work with your team, who's involved, and what we'd like you to do is identify what contracts do you currently have in place. And are there any coming up? I forget who said it. Was it the Alaska group, Leanne, that an RFI is coming out? I forgot who said that. But what have you got today? What kind of contracts? Go back, look at the PowerPoint. Kind of tell us about the contracts. What model is it? What's coming up for you? Think about what contract. Second point is think about potential for your org. What contract models might be the most logical for your organization to enter into? Like when we reviewed the DSRIP, somebody was like asking about risk. The farther the left, the less risk. The farther the right, the more risk. Where are you at as an organization? Are you willing to take on that risk? You might be willing, but are you going to lose your shirt? Are you going to shut down because you're not ready for it? So take a look at the sample contract, and again, look at the downloads. You're going to want to download this presentation. You're going to want to download the sample contract. There's also a leadership assessment. Sherry, do you think we should go through that in the interest of time, or is it self-explanatory?
We can quickly, if AJ wants to open it up. It's just a series of a couple of questions. Let's see here. I got to get it bigger on my own screen. Let's see. Can I make it bigger?
So in the interest of time, I'm just going to give a quick overview, Sherry, and you're much better at this than I am. But across the top, it has the criteria, things that you need to consider. How is your board with the vision? And you're going to go through for each type of contract. There's also quite a drop-down, Sherry?
Yeah, there's a drop down, and for some reason it's not working on the screen. I can't make it, but there's a selection criteria for each one based on the type of contract, and it's really just a baseline for you to understand kind of where your leadership is and where do you think they're ready to go, so you can actually start developing some thoughts around the clinical integration piece to support the vision of how much risk do you think you're willing to take on, say, over the next 2-3 years.
So again, this would be important for folks who are on the call today to get stakeholders involved and do the exercise together. So if you want to look at that, be prepared. I'm not sure how time is going to work out next session. Depending how many people are on the session, just be prepared. We may have everybody do a quick overview of what they found, or we may randomly pick, a couple people or ask for volunteers. But again, stay with us on the assignments. If you have any questions, carol.dahl@optum.com. Reach out to me. Be glad to help you or get you help. We have a couple of things that we owe you. I gave you the AHA definition of clinical integration. We're going to get you some more examples for the stratification, high, mod, and low. And Laura, how do I download today's screen? I'm going to let AJ answer that, and to remind folks about the Survey Monkey. AJ, you want to teach them how to download?
Yep. Okay, so on the right side of your screen, you should have a Files tab. You should see 5 different documents from today's session in there. You can download them individually, or at the bottom of that it should say download files. You should be able to download all 5 together. If you can't do that, please let me know. I'll send out an email after this session and I can send them to you individually, but it should be easy enough just to download it right there. And the other thing is, yes, I just in the chat I sent out another link to the survey. Please be sure to complete that survey. It's really helpful to all of us, as Carol was mentioning earlier in the session. So that's all I have from my end.
Great, and there's also, I failed to reference it, there's an article in there that if you want some light bedtime reading or you're commuting into work, reinforces content today and for the future. I just want to close by saying, please, please, please do SurveyMonkey, and I'm very pleased with so far the first session, the level of participation. From our experience, every session it gets more. We don't want to put anybody on the spot, but really appreciate when people talk. It's awesome. So thanks, everybody. If you have any questions, reach out, do SurveyMonkey, and we will see you back, oh my gosh, in October. October 4th is the next session. So